Hello and welcome to the Auditing Antics podcast. So today, in celebration of our spooky episode, I have my Grateful Dead trick-or-treating shirt on. Let me see if I can show it some for the camera. Nope, maybe not. There we go. You can see the crew. They're trick-or-treating. And then Michelle has her Freddy Krueger inspired shirt on. So this is one of our favorite times of the season. So we definitely had to do something a little themed here, just to add a little fun to it.
Love
So
spooky season. I love
yes,
the spooky, scary story times, I should say. I like to hear about other people's scary stories, but I don't want those things to happen to myself. So
yes, that's
we'll
true.
just
That's true.
we'll just listen to other people's horror stories.
We can keep our spookiness to a PG level. We'll do Disney spooky. That works.
Yes, yes.
Mickey and Friends.
Last year we went to it was called Hollow Scream at SeaWorld.
Hmm.
It was too scary. It was too freaky. By the end, I was just like walking through like this. I was like, la 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 la. And then at the end, you had to walk through this thing where it was like pressing all against you. It was like these two things blown up, and you didn't
Yes.
know what was going to be on the other side. Oh my gosh.
Yeah.
I don't
This
think I'll be
year,
doing that again.
no, no, I try to stay out of those. This year, my youngest daughter and her boyfriend and my husband went to a local haunted corn maze. And then there was also a second place. It was, I don't know what to call it. I guess you could call it a haunted trail because they were in the woods being chased. And
No,
it's like,
no.
never. Someone would have to carry me out of there. I wouldn't make it. All right. So today we're going to be going over some of our own coding nightmares that we've found in our audits over the years. And one thing I want to preface this entire discussion with is just a quick overview from a compliance perspective of what it is that you should be doing when you find these things. So a lot of what we're going to talk about today did result in situations where it leaves the practice or the organization in a scenario where they essentially are going to have to follow steps of an internal investigation and then going through a self-reporting scenario. So I just want to point that out. We're not going to dive into what that looked like for every single case. But I want to make it clear up front that when we talk about these more extreme situations, it does result in scenarios that you have to pursue next steps. We didn't just find this and then hands off walk away.
Hmm.
You have to then, typically engage an attorney depending on what's going on, especially if you know that that internal investigation is going to have a lot of errors that are found that are going to lead to that self-reporting. So keep that in mind. We are going to talk about some craziness today, but it does not in any way mean that you just say, "Oh, I found it and I'm going to walk away and leave it there." So,
Yeah, even if the resolution isn't discussed, it doesn't mean that there wasn't a resolution. And sometimes we do have to hand these things to the clients,
mhm.
and they have to make decisions about
Yeah.
what they're going to do going forward. And sometimes, as you know, in compliance, it can be very frustrating when you bring these concerns to a
Mhm.
client and they're like, well, we allow that according to our policy, even though
Right.
you're blatantly telling them that this is non-compliant. So I like to make sure when I'm auditing these things that I am wording in my comments in a way that make it clear that it's
Mhm.
not compliant. So regardless of what the client thinks, my finding is always going to reflect the compliance concern if it
Yes.
exists. Um,
Yeah.
so just kind of like those couple bit of preferences is, we'll talk about the stories and and things like that. But if for some reason the resolution isn't there, um, it's not that we didn't follow through with it or just
Yes.
allowed these non-compliant behaviors to slip on by.
Yes. Yep. And, that's a good point too, because what you do after you find something like this is going to look different than what I do
Yeah.
because I'm a consultant. Obviously now having my own firm, I'm going to be the main person responsible for communication, walking a client through what that looks like. If I'm working projects and it's not under attorney-client privilege yet, I'm typically going to pause and be like, hey, we need to bring an attorney in here. Or if they have one already, then I need to go to them and have a conversation before we discuss findings and things like that. So
Mhm.
you would be going to the person who's in leadership. So
Yep.
at Doctors Management, for you, that would be going to a senior consultant, like I
Mhm.
was when I was there. And then from there, they'll take it to the, the direct person and down that path that needs to go. But for me,
Yes.
it will look different. But the point is, you have to bring these things up. We don't just walk away.
You can't just
Don't
like
be a part of the
sweep it
problem.
aside and pretend you didn't see it. Sometimes these are very uncomfortable conversations that have to take place. And how I have kind of, like I just said, how I have kind of learned to mitigate that and make sure I'm not put in a place where I'm uncomfortable is making sure that my comment always reflects my concern
Yeah,
with what I am seeing. That's not only on individual claim lines, but also if I have to write a report or things like that, I make sure that I am conveying that so that they can see this is an issue
yeah, yeah,
and why it's an issue and so on and so forth.
yes, yep. All right, so let's jump into these coding nightmares, the different cases that we've worked or projects that we've worked. Michelle, I'll let you go ahead and get started with one of yours.
Yeah, so the first one that I'm going to talk about takes us back to 2021. So this was when
Man, I don't remember the years. You're good. Go ahead.
this is I only remember because this was something that came up as a result of the new guidelines
Okay,
coming out.
okay.
So this particular client, we have all these changes to medical decision making and how the level of service selected was selected, and then they also came out with these big changes to time. So this particular client decided here on out our physicians will only bill based on time. And so in my initial audit, I'm going through and as a compliance professional, I understand that only saying you can only bill based on time, you can only bill based on MDN presents its own risk. So went through and I started to pull apart each encounter showing medical decision making versus time and just uncovered all of these issues. And it actually resulted in a 100% variance on all of their providers. So here are the issues that I was seeing that made this such a nightmare. They were undercoding based on time when medical decision making supported a higher level of service, actually. And then they they were using these time statements and always billing the same time for the level of service. So if they were reporting like 99215, for example, it always said 40 minutes. My favorite was the 99204s when they decided to say 50 minutes. Well, we'll offset it a little. That will be less suspicious. You know what I mean? So we were running into all of these issues. My favorite is I have seen a provider document 32 minutes every single and bill 99214 every single time.
Mhm.
That really threw me off as to what you were doing there. Didn't pick that out whatsoever. I say that very
Don't be
sarcastically.
suspicious.
Yeah, I know. I, I just would love to know the thought process behind these things and why providers don't recognize it as like, why do you think you're not that this pattern isn't going to be seen if we look at any number of subsequent encounters that you've
Mhm.
documented. So we had to, bring this to the client, and we had to start bringing up all of the issues with, well, first we know undercoding based on time when a higher level of service is supported is an issue. So I think that's kind of a misconception that people have out there. I know when I first started coding, I often would hear the phrase, well, payers don't look at 99213s. They're never going to look
Yeah.
at that.
Oh, yeah. People think
They're,
that's the safe level.
that's not ever going to get looked at, so we don't need to look at that.
Mhm.
Okay, well, I was seeing all sorts of things in that scenario one where things should never have been billed, but we weren't looking at it because it was a 99213, or higher levels were supported. But in this particular case, we kind of had to lay that out for the client as to how that was false reporting a claim, and it really wasn't fair across the board where somebody else was paying the cost of the actual service, and this patient over here was paying less. But then on to the big issue of these times and how they were documenting time. So if they're requiring the providers to bill everything based on time, this tells me that more than likely all of their claims are going out the door
Mhm.
wrong. So when you're billing based on time, there's going to be a natural variance in the time spent from patient to patient. It's never going to be expected that each patient is going to take the exact same amount of time because there's varying levels of complexity that go along with each patient visit. And even if patients present with the same conditions, they still could be at varying levels of complexity. So there, it really takes away from the validity of that time that's being documented. It
Mhm.
really has to make you stop and wonder, this provider keeps documenting all of these identical times. Are they even measuring
No.
how much time, or tracking how much time is being spent? And you're exactly right, no, they are not. And my favorite is also, I spent greater than 30 minutes. That is
Mhm.
not any more compliant than
Well, I
document.
think a lot of providers don't realize that even some of the MACs now say they don't wanna see
No.
approximate terms,
Yes,
so we
and
need to
it's
stay
like,
away from it.
okay, so you spent at least 30 minutes of time. So that conversation looks like, what time can you confidently say you spent on this patient?
Mhm.
That's the time you should be entering. Not, I know I spent at least 30 minutes. Well, did you spend 31? Did you spend 29? Because it could sway both ways if you're really uncertain. So you need to make sure that you're billing based on actual time, and it can lead to questions, about the integrity of that documentation.
Mhm.
And the other thing I want to say about this is, when billing based on time, it should be based still. The complexity should drive the time, not your habits, not the fact that you are a hunt and pecker on the keyboard, or you know, I mean, I've seen it. I have
I
had to
know.
sit there. I've had to sit there while providers complete documentation in the most agonizing way possible. Somebody get this person a scribe. I don't know what to tell you, but it shouldn't be based on your habits. It should be based on, this time was medically necessary, not this time it took this long because I don't know how to use a computer. Um,
Mhm.
so what do we recommend to clients when we run into these? Because you I don't think we should be surprised, but um, I run into this all the time. I run into the times being the same, um, and billing high levels of complexity, whether the patient is presenting with chest pain being sent to the ER, or they come in with a cough and are diagnosed with sinusitis. It's like, what
Yeah.
what did you do for 40 minutes? Uh, you know what I
Yeah.
mean? You told them Tylenol,
Right.
hydration. It leads you to believe, does this statement really reflect the care that you've had? So make sure that the time documentation is always representing the actual time. And it's not to say that it's not going to that there won't be times where it will only take you 30 minutes, where it will only take you 40 minutes. But I don't think that's going to be the exception, or that's not going to be the standard that you're going
Right.
to see. And you want to make sure that your time statements describe how the time was spent. And I don't know about you, Stephanie, but a lot of times we see these macro statements being blown in where they're like, let's put all these typical activities that we
Right.
do in here. My favorite is reviewing labs and tests. But then when you look at the note, nothing is documented.
Yeah, it
So
doesn't
now we
come
have
full circle.
no, now we have a contradictory statement. So
Yeah.
when you're having these time statements, I do think there should be a level of encouragement to be free texting what you actually spent your time on, because that also is going to vary per
Right.
patient. It's not
Right.
something that I don't think you could say across the board what you substantially spent your time on and it be the same for every patient. It's just not true. And then
Right.
you
It's not
also
gonna happen.
no, and if you have a provider who is billing predominantly based on time, I understand that there are certain specialties. One that comes to mind is hematology oncology. A lot of them are counseling based. Um,
Yeah, that will
so
definitely happen.
so you see that, but be comparing that time in medical decision making consistently. I know it's like, awesome, we have time, push it out.
Yeah.
You have to compare those. Like you have to take
Well,
the
and this is a really good example of 100 something that results in 100% denial.
Mhm.
That then is an even bigger problem because administratively someone directed them to do
Mhm.
that. And then it's going to open a whole other can of worms. So yes, that for sure is quite an issue. And one thing I want to say quick to finish that one out is that when you are looking at these things, you have to remember that we can go into like the False Claims Act, for example, and that's going to show us that undercoding and overcoding both are variances. And
Mhm.
depending on what type of review is done, it's not like you're always going to have an external review and they're just going to be like, oh, we're fine. You undercoded yourself. We'll walk away from you and not look at you. That's not how it works. And I think that's how a lot of people think that that's going to come about.
Yeah.
Now, we'll go on to the next case. I know we're going to be close on time today. So with my case, this was something where I was doing audits. It was under attorney-client privilege, and the provider was already being investigated by a couple of payers. And pretty much what happened is he was looking to hide the drug that he knew that he was infusing that was not covered by insurance. So this is back years ago when ketamine was a huge thing at the time, being used for a lot of behavioral health purposes. For example, it was not FDA approved at the time for that purpose, which means we can't be billing the insurance. So they were trying to be creative in the way that they were doing this, like adding an E&M every time the patient came for an infusion, which of course was not supported. And then on top of it, just billing out the infusion administration and leaving the J code off because they didn't want to show that that was ketamine. So it's
Oh.
like just looking at billing data, there were big red flags because, obviously this is going to be an issue. And for me, I like to look completely at everything, meaning that if I have some concerns, I'll start looking at the practice website and all these other things. And one of the first things that stood out to me, I shouldn't laugh. This is this is bad that I'm laughing, but we had this huge coding nightmare. And I go on the website, and one of the things that I see is that the clinic name had the word ketamine in it, and it was on the building, and the doctor had a picture of him in front of the word ketamine on his building on his website. So it's like, okay, you're hiding the drug that you're infusing, but yet you just announced it to the world and have it right there for anyone to see. And if you're under investigation, with the payers, they're going to be digging in everywhere. Any
Yeah.
public source they have, as far as a website, Google Maps, Google Earth, like all of these things. And he just displays it wide open right there. So, that definitely resulted in a full refund situation. That, like I said, it's really hard not to laugh at that. A lot of people, I think the scary part of this in the industry is that a lot of people think that they're not touchable. Um,
Yes.
this particular physician has, what I would say is a chip on his shoulder because of all of the research work that he did during his fellowship. And not to downplay that, because a lot of the things that are considered to be investigational and experimental really do great things
Mhm.
for patients and for their health and the particular problem that they're targeting, but it doesn't coincide and equal with compliance and coding and reimbursement. That's really largely going to have to be a self-pay service.
Mhm.
So, that physician was really difficult to work with because of, honestly, his ego. And, he felt like even though he was in situations of giving money back, that he still was going to be untouchable. So that took a lot of working with the attorney, and thank goodness that was underprivileged and with an attorney, and, working through the investigations, and then also his situation of needing to do his own internal investigation. Um, but
Yeah, and
that was, again, 100% denial rate, and it included not only infusions, but he was taking cash from the patient for the drug itself, which is also an issue. And there was a lot involved in the follow-up work after that was all found.
yeah, and in those scenarios, you also just can't stop treating your patients. Like,
Right.
you
Well,
there
yes, that's a
there's
concern.
there's
Yeah.
a, trickle down effect of these things as well. So it sounds like that was a horror for more than one reason. Maybe
Yeah.
not just compliance.
Yes. Yeah.
But that is, I mean, it is kind of comical. I'm
Yes.
going to be as public as I can about it, but also try to hide what I'm doing and then
Yeah,
act
I
appalled.
yes, I'm kind of shocked when I get to talk with different investigators in the industry, and, you know, um, just find out what they do, the lengths they'll go to look into a particular physician they have concerns with. And, that also, that type of thing, which this isn't my space, you leave it up to the attorneys, but it calls into question the intent of the provider. And, that can lead you down a path of the criminal side of the industry. And no, thank you. Like, let's not do that. Now,
Yeah.
Michelle, I have one more I want to go through
Yeah.
for this episode, and this was in an unfortunate situation. So this was one, I can tell you, the physician's heart was in the right place, ethics were in the right place. Very, very good person, cared a lot about patients. Thought he was doing a service for his local community who did not have, access to as much care at the time. But what had happened is it was one of these situations where they were approached by another entity. They wanted this physician to come in and take care of orders for home infusions and then
Mhm.
do the supervision of those services. And to make the scenario shorter, at the end of the day, basically what happened was he listened to a consultant from another company who wanted to benefit off of his involvement, and then it resulted in him creating an entire company during the time of COVID, which was 100% non-compliant because they had followed hospital policies that did not pertain to a private practice. It was only specific to outpatient clinics that were associated with a hospital facility. So, digging that apart was really, it was hard for that physician in his practice because, like you said, you have to think clinically about the
Yeah.
patients. You have to make sure you're not medically abandoning those patients. But that also resulted in a lot of legal work and, me having to work with the attorney. And that was a mutual one that Sean Weiss and I had. And, it's hard when you have to have those conversations and those, again, nightmarish situations where everything you've received in reimbursement was not compliant, and you've now got to walk back because, we look at
Mhm.
every angle. Okay, what about this policy? What about this, waiver during COVID? And what it came down to is that other entity with that other consultant did not provide them with entire documents. They took snippets of the different waivers and the policies to make it fit a scenario. And if they had seen the entire document, sometimes the very next paragraph provided the clarification that it wasn't applicable to their situation.
Yeah.
So, it's those ones I have a hard time with. I always say, yes, I'll geek out on the compliance and the coding side because I love digging in. I love doing the forensic auditing, the research, all of those things. But at the same time, when all of that work is done and we sit and have those conversations with our practices, then the personal feelings come in some, because they had good intent, those patients
Yeah.
benefited from the services, but there's a lot of things that people don't do preventatively that put them in bad situations. And one last thing I'll say about that, and I'll let you close it out, Michelle. That's one of the main reasons I wanted to start this podcast, because a lot of times when I am working with people and we're in these unfortunate situations, there's things that, they'll just say a lot. I hear it all the time. I didn't know that that policy existed. I didn't know I needed to look. I didn't know I couldn't trust someone who had the consultant name with credentials after it. That it's just difficult, but hopefully as we continue, and I know the work I do every day, works
Mhm.
towards getting the word out there, making this better, helping people navigate the scenario, and hopefully not end up in your own coding nightmare.
Yeah, and one thing I'll just add to that is we see this a lot with people selling devices or like services or workflows or things. And if somebody is approaching your practice saying we can increase your revenue and provide you this service or with this device or with this treatment, you need to make sure you are doing external research. Do
Mhm.
not depend on this person who is trying to sell you something to give you the accurate information.
Right. Now, along that same line, I just want to let everybody know. So next week, I'm going to have Ron Chapman on the podcast with me. He's a good friend of mine, a colleague in the industry. I do consulting work with Safe Harbor Group, which is his
Mhm.
consulting firm as well. And if you don't know Ron, you should look into him before the episode next week. He is pretty amazing. He's a federal criminal defense attorney, and the work that he does in this industry, again, same thing. That's kind of how him and I started to work together, is that he wants to help people, but before it gets to the point of him having to defend them at the level that he does in federal court. So stay tuned for next week. Ron and I are going to break down different UPIC cases we've been working on in wound care
Mhm.
with skin substitutes and
Yeah.
all of that. And I'm excited to get into that. And of course, if you enjoy the spooky season like Michelle and I do, have a good rest of the week and a good Friday. I know I'm looking forward to it with my grandson. It's the first year we're going to take him out and do a little trick or treating. So he
He's
can't,
gonna be so cute.
yes, he cannot have all of that candy, but we're going to go out and have some fun. So, all right, we'll see everybody back next week.
All right, bye.